Hello, I'm Mark Sabatine, chair of the TIMI study group at Brigham and Women's Hospital and a professor of medicine at Harvard Medical School. And I'll be speaking about non-ST elevation acute coronary syndromes. Here are my relevant disclosures. So as we think about the acute coronary syndromes, this slide presents the paradigm between non-ST elevation ACS on the left and ST elevation ACS or STEMI on the right. We'll be focusing on the non-ST elevation acute coronary syndromes, which are due to plaque rupture with a subtotal coronary occlusion, as shown on the graphic on the upper left. That may or may not lead to some ECG changes, could be ST depressions, as shown on the ECG inset there. There may also be T-wave inversions, which aren't shown here. But importantly, there are not ST elevations. That's shown on the right when you have complete occlusion of the coronary artery. So we'll be focusing on the left-hand half. The non-ST elevation acute coronary syndromes can be further subdivided into the non-ST elevation MI, or unstable angina. And as I've indicated here, what qualifies for a non-STEMI is biochemical evidence of myocyte injury, nowadays with an elevated troponin, and I'll talk about CK-MB in a minute. So an acute coronary syndrome, which leads to subtotal coronary occlusion, will then not produce ST elevations, so we're in the realm of the non-ST elevation acute coronary syndromes. There may or may not be ST depressions, there may or may not be T-wave inversions. If the biomarkers are elevated, then we have a non-STEMI, otherwise we have unstable angina. Now, this slide covers the utility of biomarkers in the setting of acute coronary syndromes as it's evolved over a fair bit of time. And so what I have glibly deemed ancient history is the state of affairs when many of us first trained, where CK-MB was the cardiac biomarker of choice. And we would measure levels serially every 8 hours for 3 measurements, so spanning a full day, to determine if the patient has ruled in for a myocardial infarction. There was the dawn of modern cardiac biomarkers with the advent of the cardiac troponins, which came into being in the 1990s. And the initial timing of the assessment mirrored what we had historically done for CK-MB, which are measurements every 8 hours over the course of 24 hours. More recently, we've appreciated with contemporary cardiac troponin assays the greater precision at the lower end of the range enabled us to reliably detect myocyte necrosis much earlier in the process. And so patients would only need to have a measurement at presentation and then one 3 to 6 hours after symptom onset. And now, currently, with the advent and approval now in the United States of high sensitivity troponin assays, now there are a variety of algorithms that have been validated, all of which have obviously a measurement at presentation, but then another measurement either 1 to 3 hours later, the later one being if the presentation is early, within 3 hours of symptom onset. And then one would look at not only the absolute values, but also the absolute change between the first one and the repeat measurement. And either if the absolute values cross the 99th percentile, or if the delta indicated a significant rise, then those patients should be admitted and classified as a non-STEMI and get the appropriate workup. So now it has really shortened the time to make the diagnosis with more sensitive troponin assays. So as we think about the likelihood of a patient in front of us having an acute coronary syndrome, this was a very helpful table that appeared in a few iterations ago of the unstable angina non-STEMI guidelines, now about a decade ago. But I find the table still helpful to integrate what we would use, the history, the exam, ECG changes, and biomarkers. And then that's for diagnosis, but then also we need to keep in mind prognosis, and there are a variety of prognostic risk scores available. One that Elliot Antman and our group developed was the TIMI risk score for unstable angina non-STEMI. It uses 7 easily determined variables listed here on the slide. And you can see a very clear gradient of risk for death and ischemic complications based on the number of risk factors that a patient has. And this score has been useful not only for prognostication, but also for determining which patients benefit more from more aggressive therapy. Okay, now for the rest of the talk, I'm really going to transition from diagnosis, which I only touched on briefly, and really for management issues for non-ST elevation ACS, where there really is a broad range of possibilities. I'll start with the anti-ischemic therapy. That'll be familiar to most people. Nitrates are given for symptomatic relief by causing venodilation and a decrease in preload, and perhaps also some component of relief of arterial or vasospasm. There is no mortality benefit, but it's useful for symptomatic relief. Beta blockers certainly decrease ischemia. They decrease the risk of death and recurrent MI. But the guidelines now, in a change over the past several years, now call for oral beta blockers and not intravenous. And the oral beta blockers only if the patient is not in heart failure or at risk for shock. And I'll touch on that in the next slide in more detail. Calcium channel blockers, if ischemia despite maximal beta blockade, or there are contraindications for beta blockade in terms of reactive airway disease, for example. Morphine to treat pain, heart failure, agitation, but remember not to mask the angina. If a patient has refractory angina, you don't want to render them pain-free by just giving them escalating doses of morphine. Instead, that's someone who would be considered for going to the cath lab, and I'll touch on that later as well. And then supplemental oxygen if they're hypoxemic. This details in a little more detail the shift in the guidelines for beta blockers, and this came about now about a decade ago, but is not widely recognized by people. And based on some more recent trials that looked at high doses of beta blockers given reflexively to all patients coming in, and showing a counterbalance in terms of benefit for decreasing ischemic events, but an increase in causing heart failure and pump failure events. The guidelines now have tapered, sort of, if you will, the enthusiasm for high-dose beta blockers early on, and really stress that it should simply be oral beta blockers that should be initiated in the first 24 hours if patients are without any of the following: heart failure, low output state, or increased risk for cardiogenic shock. The risk factors I list below at the bottom, but keep in mind one of the risk factors is tachycardia, a heart rate greater than 110. Oftentimes reflexively in the emergency department, there'll be a desire to start beta blockers if the heart rate is high. And that may certainly be useful to decrease myocardial oxygen demand. But keep in mind that that patient may be tachycardic because they're slipping into heart failure and their stroke volume is low, and they're compensating with a tachycardia, which if you were to take away, they would spiral into cardiogenic shock. So do be careful about that for beta blockers early on. We'll talk about beta blockers at the time of discharge. So oral beta blockers, go gradually, make sure you don't precipitate heart failure. Okay, so now for the non-ST elevation ACS, really a critical branch point is thinking about, after patients have gotten their initial medical therapy, do you follow a so-called invasive or routine angiography approach, or a conservative or selective angiography approach? On the upper half of this slide, we show the invasive or routine angiography approach. In this approach, all patients go to the cath lab to define their anatomy, and then they would have revascularization, either PCI or CABG, based on their anatomy. The lower hand side, the conservative therapy, patients continue on solely with medical therapy, and then they undergo a stress test. And either if they have recurrent angina while they're waiting for their stress test, or if they have a high-risk result for their low-level stress test, then they would go for angiography. So that's why it's called selective angiography. Otherwise, they would just be managed conservatively. And in a meta-analysis that Michelle O'Donoghue in our group led several years ago, looking at 8 randomized controlled trials of an invasive versus a conservative strategy, you can see overall that the invasive strategy was superior, with a 22% reduction in the risk of death, MI, or rehospitalization with another acute coronary syndrome, with most of the benefit coming for preventing reinfarction or rehospitalization with an acute coronary syndrome. As I noted earlier, risk stratification is an important part of the management of patients with non-ST elevation ACS, and this shows application of troponin for risk stratification. This is one of the 8 trials that was on the slide before, Tactics TIMI 18, where we compared an invasive versus conservative strategy, invasive in the crimson and conservative in the royal blue. And you can see that and overall in the trial, invasive was superior. Here you can see for patients who presented with an elevated troponin, so non-STEMI, those patients had a very big reduction in death, MI, or another acute coronary syndrome through 30 days with the invasive approach. Conversely, patients who presented with unstable angina without elevation in their troponin level, they had no benefit for an early invasive approach. So that's why the decision for an invasive approach can be guided by a biomarker elevation and other factors. The other question is, if one does do an invasive approach, then when should that patient be brought to the cath lab? And the TIMAX trial looked at this comparison, either bringing patients in within 24 hours, typically sometime in the middle of the first day, so a median of 14 hours, or waiting at least 36 hours, and the average wound up being about 2 days or so. And overall, though the trial didn't quite achieve statistical significance for the composite of death, MI, or refractory ischemia, an early invasive approach was superior, and not shown here, but particularly good in patients who were at higher risk. And so integrating all that information, when we wrote the 2014 non-ST elevation ACS guidelines, the way we framed it was going here from left to right, that patients should go immediately to the lab if they have refractory angina or symptoms of heart failure. Patients should then have an invasive approach, and particularly an early invasive approach in the first day, if they have an elevated troponin or ST depressions or an elevated GRACE score, another risk score out there. Otherwise, if they're a higher risk patient because of who they are, meaning their diabetes, they have a chronic kidney disease, their ejection fraction is low, they've had a recent revascularization, those are patients who also are reasonable candidates to go to the cath lab, but because the episode for which they were admitted wasn't quite as severe, there's not an elevation in troponin, there's not ST depressions, those patients can go to the cath lab in the first 72 hours, doesn't need to be in the first 24 hours. And then a conservative approach would be for low-risk patients. Now, let's dive into antithrombotic therapy. So first, let's talk about antiplatelet drugs. And we always start with a cyclooxygenase inhibitor, namely aspirin. We'll then layer on top of that, we'll add to that a P2Y12 ADP receptor blocker, such as clopidogrel, prasugrel, or ticagrelor. And then sometimes we may also add a third antiplatelet drug, a glycoprotein 2B3A inhibitor, psiximab, eptifibatide, or tirofiban. And I'll go into these in more detail. The anticoagulants is an easier approach. There we just need to choose one. We're not layering multiple anticoagulants on. Unfractionated heparin, with which everyone is no doubt quite familiar. Low molecular weight heparin, particularly enoxaparin, as an alternative. The direct thrombin inhibitor, bivalirudin, would be another option. And fondaparinux is a pentasaccharide blocker, has some data for it, but it is essentially not used in this indication. So for the antiplatelet therapy, this shows in the schematic a platelet in the middle shown in gold there. And you can see here aspirin blocking cyclooxygenase that prevents the formation of thromboxane A2, which is a platelet agonist and vasoconstrictor. So you block that. The ADP receptor blockers, clopidogrel, prasugrel, ticagrelor, and ticlopidine, which is not used in the cardiovascular space, block the ADP receptor. And then the 2B3A inhibitors block the final pathway for platelet aggregation. So aspirin we give to all patients, barring a contraindication, and typically a loading dose of 162 to 325 milligrams. Now, why do we add additional antiplatelet drugs? The CURE trial helped put onto the map treating patients with non-ST elevation ACS with clopidogrel. We're adding clopidogrel to patients being treated with aspirin and heparin, resulted in a 20% reduction in CV death, MI, or stroke. Then more potent ADP receptor blockers were developed. Prasugrel is one of them that was studied in Triton TIMI 38. And you can see that as compared with clopidogrel, prasugrel resulted in a further roughly 20% reduction in ischemic events with about a 2% absolute risk reduction, although this came at the cost of more bleeding, in this case about a 0.5% absolute increase in bleeding. The other newer P2Y12 inhibitor is ticagrelor, also more potent than clopidogrel, and in a large trial shown here to reduce events compared with clopidogrel by 16%. And importantly, also reducing the risk of cardiovascular death by 21%. But like prasugrel, it causes more bleeding, at least more non-CABG related TIMI major bleeding. So when we formulated the guidelines, then we noted that while certainly there's data for each of the drugs, given the superiority of ticagrelor and prasugrel over clopidogrel, there are 2A indications to use those drugs instead. I should note that ticagrelor was studied in all comers coming in with ACS. So regardless of the management strategy of medical management or invasive management, that would be fine. Prasugrel was studied only in patients with planned PCI, so it's really only indicated for those patients where there's a plan to do PCI on the culprit vessel. The 2B3 inhibitors I won't go into more detail for. They are very potent antiplatelet drugs. Typically, we consider giving them at the time of the PCI itself, so it's mostly decided by the interventional team and mostly based on how the PCI is going. Anticoagulants, as I mentioned, this is somewhat simpler in that we only need to choose one. We're not layering multiple anticoagulants on board. Unfractionated heparin we're most comfortable with, fast on, fast off. Low molecular weight heparin has more predictable pharmacodynamics, although it's not as reliably reversed as unfractionated heparin. And compared with unfractionated heparin, reduce the odds of death or MI by close to 10%, but may increase bleeding. Probably most efficacious in the setting of patients being managed conservatively, where they're going to stay on their anticoagulant for about 48 hours before having their stress test, then having a more reliable anticoagulant with fewer sort of peaks and troughs makes more sense then. Bivalirudin, also a fast-on, fast-off drug. Compared with heparin, it does have a slightly higher rate of MACE, particularly stent thrombosis, but does cause less bleeding, and certainly less bleeding if you compare it to unfractionated heparin plus a 2B3A inhibitor. And so bivalirudin is a drug that largely we consider in invasively managed patients, especially if they're at high risk for bleeding, to use that instead of unfractionated heparin. And so the guidelines here note that you can give any of these drugs and note that if the patient's at high risk for bleeding, it's reasonable to use bivalirudin monotherapy instead of unfractionated heparin plus a 2B3 inhibitor, although it's rare that we use a 2B3 inhibitor nowadays. Okay, now another question is how long to give these drugs. Certainly for the anticoagulants, we stop the drug after the PCI or at the time of discharge, but we continue the aspirin and we continue the P2Y12 inhibitor. We have traditionally stopped the P2Y12 inhibitor at 1 year for the simple reason that the original trials that studied them only went on for about a year. But in this landmark analysis done from the CURE trial, you can see that adding clopidogrel to a regimen of aspirin and heparin while they were initially in the hospital, but adding clopidogrel long-term decreased events not only over the first 30 days, as shown on the panel on the left, but continued to decrease events with the curves continuing to separate out over the ensuing following 11 months. And similarly for both Triton TIMI 38 and for Plato, you can see in these landmark analyses that the curves continue to diverge over time, suggesting that prolonged P2Y12 inhibition beyond 1 year would lead to additional benefits for patients. And that's exactly what we saw in the Pegasus TIMI 54 trial, large trial, over 21,000 patients who had a history of MI 1 to 3 years prior. At that point, they were just on low-dose aspirin therapy. We then randomized them to ticagrelor or placebo. The ticagrelor given in 2 different doses, either the standard 90 milligrams BID or a somewhat lower dose of 60 milligrams BID, and both actually reduced ischemic events by about 15 to 16% or so. Now let's transition to some other long-term therapy. I talked about some of the concerns for giving high doses of beta blockers reflexively in all patients when they present. And so that's why the guidelines urge some careful dose titration in that setting. But certainly I do want to underscore the benefit of beta blockade for patients at the time of discharge. And these are older trials, but clearly show that for patients who had an acute MI, for beta blocker versus placebo, 45% reduction in mortality with beta blockade, 28% reduction in reinfarction. So we absolutely do want to be sure that we send our patients home on beta blockers. We just want to be cautious when we first initiate them, when we're first meeting them in the emergency room. Now, what about other risk factor modification, particularly LDL cholesterol? So in the PROVE-IT TIMI 22 trial, we compared intensive statin therapy with atorvastatin 80 milligrams versus moderate therapy with pravastatin 40 milligrams. And you can see the superiority here of the more intensive statin regimen, which achieved an LDL cholesterol under 70 milligrams per deciliter, here about 62 milligrams per deciliter. And the basis of this trial and other trials, the guidelines were then updated in 2004 to recommend intensive statin therapy, high-intensity statin therapy, so drugs like atorvastatin 80, for example, or rosuvastatin 20 or 40, to decrease the risk of ischemic events in patients and to consider a target of achieving an LDL cholesterol less than 70. Well, we then went on to try to build on that and did the IMPROVE-IT trial, where for patients, again, stabilized after ACS, we randomized them to get a statin alone, in this case simvastatin, where the achieved LDL in the control arm was 70 milligrams per deciliter, so like the experimental arm in PROVE-IT TIMI 22, and what the guidelines would recommend. And here the experimental arm was to add ezetimibe, which reduces LDL cholesterol by about 24%. And you can see they're dropping the levels down into the mid-50s. With that then resulted in a reduction in the risk of cardiovascular death and other ischemic outcomes here. And although the reduction here was of a relatively small magnitude of 6.4%, keep in mind that the control arm had extremely well-treated patients with an LDL of 70 milligrams per deciliter that is far better than is typically achieved in clinical practice. And so we know that the benefit of LDL lowering is simply going to be proportional to the absolute reduction in LDL cholesterol. And on this XY scatter plot, you can see a whole variety of statin trials that were put together by the Cholesterol Treatment Trialist Collaboration. And from this analysis, we have the notion that for a millimole per liter reduction in LDL cholesterol, about 40 milligrams per deciliter, we achieve about a 20% reduction in risk. Where does improve-it fit on this graph? It fits exactly on the graph that given the LDL reduction we saw in this well-treated population, we would expect exactly the risk reduction that we saw. So reinforcing the notion that we want to get the LDL cholesterol down, in this case even down to levels in the mid-50s, we continue to see benefit. Now, the next advance in the field of LDL cholesterol management, or the PCSK9 inhibitors, we studied one, evolocumab, in the Fourier trial. Evolocumab on top of a statin decreases LDL cholesterol by close to 60%. Here we got levels down to a median of 30 milligrams per deciliter, really an unprecedented low level of LDL cholesterol. And as you can see on the right, that further lowering of LDL cholesterol resulted in a further reduction in ischemic events, about a 20% reduction in CV death, MI, or stroke, and the drug was safe and well tolerated. Similar results were recently been presented, although not yet published, looking for a different PCSK9 inhibitor, alirocumab, which again, when added to background statin therapy for patients with a recent MI, reduced the risk of events by about 15%. And so, based on these data, there have been consensus statements for LDL levels coming from the American College of Cardiology while we wait for the formal guidelines, now noting on a somewhat busy graphic here, but that if the patient still has an LDL cholesterol that isn't less than 70, i.e. if their LDL cholesterol is greater than 70, then consider further therapy here, and one can consider, in addition to making sure that they're adherent for all their meds, then consider adding a non-statin medication, either ezetimibe or a PCSK9 inhibitor, to further drive down their LDL cholesterol. And in fact, I would argue that I think one should achieve even lower levels. If you look at Fourier, we had about 2,000 patients who actually entered the trial with an LDL cholesterol less than 70 milligrams per deciliter. They started at 66 milligrams per deciliter. That's a level that before we did this trial, if I saw a patient in the office with that level of LDL cholesterol, I would think they're well treated, and there wasn't really anything more for me to do to lower their risk, at least with regard to LDL cholesterol. But you see here in the trial, when we gave them evolocumab, we reduced their LDL down to 21 milligrams per deciliter. And this group benefited just as much as they did in the overall trial. You can see here a 30% reduction in CV death, MI, or stroke for those starting with an LDL cholesterol less than 70, namely 66 milligrams per deciliter, reducing them down to 20 milligrams per deciliter, reduced their risk of death, MI, or stroke by 30%. So there is more to do for these patients. And in fact, in a nice analysis that Bob Giuliano did in the Fourier trial, looking at achieved LDL cholesterol and outcomes, you can see this monotonic, nearly linear relationship stretching all the way here from 174 milligrams per deciliter down to lower risk. This is the risk here of CV death, MI, or stroke. The lower your LDL cholesterol, the lower your risk of CV death, MI, or stroke, with the relationship extending clearly below 20 milligrams per deciliter. Other therapies to consider, certainly ACE inhibitors. We know for patients who've had an MI and have a reduced ejection fraction, even if they don't have symptoms of heart failure, Mark Pfeffer and colleagues here at the Brigham nicely showed a reduction in mortality by adding captopril. We know in general for ACE inhibitors for all patients with acute MI that there is a benefit, a 7% reduction in mortality, although I will note that that benefit is largely in those with anterior MI. And certainly again for patients with a recent MI, and if their ejection fraction is low, and either they have symptoms of heart failure or they have diabetes, which we know is another high-risk group, then they benefit by having an aldosterone antagonist added, in this case a eplerenone in this trial, but you can see a 15% reduction in all-cause mortality. So additional disease-modifying therapy we should consider. So let me summarize the results here before we go into the three cases. So certainly one should diagnose an acute coronary syndrome using the history and physical, 12-lead ECG, and troponin. In this case, we talked about the non-ST elevation acute coronary syndromes. We'll have a separate lecture on ST elevation MI. So these are patients who might or might not have ST depressions. They might or might not have T-wave inversions, but they don't have ST elevations. And if they have a positive troponin, then they'd be diagnosed as a non-STEMI. If they don't have a positive troponin, then they'd be unstable angina. The first question then for the management would be an invasive versus conservative approach, and in general, the higher risk for the patient, the more likely we would follow an invasive approach, meaning routine angiography for those patients. And again, the higher risk they are with a positive troponin, ST changes, more likely we would then take them to the cath lab within the first 24 hours versus out to 72 hours if they're a higher risk patient, but their actual presentation wasn't high risk and that their troponin wasn't elevated, the ST segments weren't shifted. Otherwise, if they were low risk, then conservative therapy, meaning continue the medical management and then have them undergo a low-level stress test and see how they do with that, and only if that is significant, and then you let them exercise obviously as much as they could if they didn't have a diagnosis of MI. If that test has high risk findings, then you bring them for angiography. Otherwise, they're managed just medically. When patients come in for anti-ischemic therapy, beta blockers, noted here to give it orally, start slowly, make sure they tolerate it. It's a marathon, not a sprint for the beta blockers, and nitrates for symptomatic relief. Then you have to select your antiplatelet regimen. Aspirin is going to be the foundation with a loading dose of 162 to 325, and then low-dose aspirin of 81 milligrams or less daily thereafter. We typically then will add a P2Y12 inhibitor. Ticagrelor or prasugrel is going to be preferred over clopidogrel. And then sometimes we'll add a glycoprotein 2B3 inhibitor, but that's typically added at the time of PCI based on how the intervention is going and residual thrombus burden in the infarct-related artery. Then we would select one anticoagulant, either unfractionated heparin, low molecular weight heparin, or bivalirudin. In most cases, you're likely to be using unfractionated heparin. There are data for low molecular weight heparin, particularly enoxaparin, being superior to unfractionated heparin. Typically for conservatively managed patients is where the low molecular weight heparin, with its more stable and more predictable pharmacodynamics, really shines in that setting. And bivalirudin is a drug that we use for patients in which we're concerned for bleeding for them and want to give a somewhat gentler anticoagulant regimen. And then long-term therapy, we talked about in terms of antithrombotic therapy, low-dose aspirin, a P2Y12 inhibitor. We've reviewed data where we actually showed the benefit extends beyond 12 months, and so it's reasonable to do it for at least 12 months and consider extending the therapy, particularly if the patient has tolerated the therapy in the first 12 months and if they're at high risk for ischemic events. We would give beta blockers. We mentioned the caution when we initiated them when the patient comes in the emergency room, but we certainly want to send them home on beta blockers. And then for a lipid-lowering regimen, for sure a high-intensity statin. And I think we've now reviewed data for ezetimibe and PCSK9 inhibitors, showing how when they are added to a statin regimen, they reduce LDL cholesterol and reduce ischemic events. And then ACE inhibitors and aldosterone inhibitors, certainly for the larger MIs, but even the non-STEMIs, depending on what the ejection fraction is or other symptoms, those are other drugs we'd like to add on. Let me, in the remaining minutes now, go through three cases. So case number one is a 68-year-old man who presents with substernal chest pain at rest that's lasted for about 10 minutes or so. Past medical history is notable for a prior MI. And for that reason, the patient is taking aspirin chronically. On presentation, the blood pressure is 150/85, the heart rate 92. The ECG shows ST depressions in leads V4 through V6. The high sensitivity troponin is elevated. The creatinine is 1.0. And the question then is, what is the most appropriate treatment strategy for this individual? And I show here the possible answers, either an invasive approach or a conservative approach. And so the correct answer for this patient would be the invasive approach. So this is a high-risk patient. Note that in the history we commented that the patient had an elevated troponin, they had ST depression, so that puts them in a high-risk category where we know from randomized trials of invasive versus conservative therapy that overall there's a benefit to invasive therapy, but that benefit appears to be particularly true in patients who are high risk as defined by a positive cardiac troponin. The other issue to keep in mind is whether there are any contraindications to cardiac catheterization for the patient, which there weren't, and that was noted with a creatinine that was normal at 1.0. Okay, let's go on to the next case. Case number 2 is a 78-year-old woman who presents with substernal chest pain at rest for approximately 5 minutes. Her past medical history is notable only for hypertension. She's in fact hypertensive on her presentation. Her blood pressure is 155/90. Her heart rate is 80. ECG is notable for ST depression seen in lead V5. The high sensitivity troponin is normal. The creatinine is 1.5, and based on that, one opts for a conservative strategy for this patient. And one could debate that, but let's leave that aside for a minute. The question here is, in addition to aspirin, what other antiplatelet therapy would you give for this patient? Let's go through the possible answers. One is to treat her with clopidogrel, a 300 milligram load, and then 75 milligrams daily. The other option is to give prasugrel, a 60 milligram load, and then 10 milligrams daily. Ticagrelor, 180 milligrams load, and then 90 BID. So these are all the standard regimens for the drug. Or to give abciximab bolus and an infusion. So let's think what the right answer would be. So the correct answer in this case is C. Ticagrelor, we know, is preferred to clopidogrel. So if we're thinking that this patient is going to get a P2Y12 inhibitor, and as we talked about, on top of aspirin, which will be the foundational antiplatelet therapy, we're going to add an additional drug, a P2Y12 inhibitor. And then we have 3 of them listed here: clopidogrel, prasugrel, and ticagrelor. Well, there are multiple reasons to choose ticagrelor. First is that in the randomized controlled trial of ticagrelor versus clopidogrel, ticagrelor was superior to clopidogrel, reduced the risk of death, MI, or stroke by 16%, reduced the risk of CV death by 21%. So ticagrelor would make sense to be a better option than clopidogrel. There was a trial of prasugrel versus clopidogrel where, again, prasugrel was superior to clopidogrel with a 20% reduction in ischemic events. However, in that trial, that was restricted to patients with planned PCI. I noted in this case that the patient was going to be managed conservatively. And so once you're in the realm of conservative therapy, i.e. the patient is not going for PCI, then that takes prasugrel off the table. In fact, for a trial for prasugrel for medically managed patients, there was no clear benefit. So prasugrel is off the table for that. Ticagrelor is superior to clopidogrel, so that tells us C is better than A. And then abciximab bolus and infusion wouldn't be appropriate. Those drugs are typically given again for patients who are being managed invasively. Those are largely cath lab-based drugs. And again, this patient's being managed conservatively. So for that reason, D can also be eliminated as a choice, and that leaves us with choice C. Okay, let's go on to the last case. Here we have for case number 3 a 56-year-old man who presents with a non-STEMI. He has a history of hyperlipidemia, an LDL cholesterol of 85 milligrams per deciliter, already on atorvastatin 80 milligrams, and he does not have diabetes. He undergoes successful PCI with placement of 2 drug-eluting stents to his left anterior descending coronary artery. He's asymptomatic. His LV ejection fraction is preserved. What's the best long-term regimen to reduce the risk of future CV adverse events for this person? Okay, so we have a variety of regimens here. Let's go through them. Each one's complicated. So one choice would be aspirin plus a P2Y12 inhibitor. So that'd be something like clopidogrel or prasugrel or ticagrelor for 3 months, a beta blocker only if the patient's tachycardic, and a statin to achieve an LDL cholesterol of less than 100 milligrams per deciliter. Choice B would be aspirin plus a P2Y12 inhibitor for 12 months, a beta blocker, and a high-intensity statin. Choice C would be aspirin plus a P2Y12 inhibitor for at least 12 months. If they're tolerating it, continue it for longer, a beta blocker, a high-intensity statin, and then also consider adding a ezetimibe or a PCSK9 inhibitor to achieve an LDL cholesterol well below 70 milligrams per deciliter. So think about what the correct answer is. So I would say that the correct answer is C, although I will point out that choice B is certainly reasonable per the 2013 and 2014 guidelines, but I think that the data has evolved since then. But let's walk through it because there are multiple options here. I really packed a lot into this question. Let's start with option A. First of all, the P2Y12 inhibitor for only 3 months, well, that's shorter than the trials which showed benefit out to at least a year, and as I indicated, there's benefit even beyond that. I'll get back to that point. So that regimen's odd. The P2Y12 inhibitor is, I think, for too short a period of time. The second odd part for that choice is that the beta blocker only if they're tachycardic. Well, that's not right. I showed you data for long-term beta blockade that has a huge reduction in mortality. So it really should be beta blocker for all patients, not just to control heart rate. And then the statin to achieve an LDL cholesterol of less than 100, that's a much older target that dates back now to maybe 15 to 20 years ago. So I hope no one chose option A. Option B is not unreasonable. It has the P2Y12 inhibitor for 12 months, which is an okay time frame. It has the beta blocker and a high-intensity statin. And that would be an okay regimen and would currently adhere to the guidelines. What the guidelines also speak to is that one could consider extending the P2Y12 inhibitor for greater than 12 months if tolerated. That's not a class 1, but it's worth considering that option. The beta block remains the same, high-intensity statin, but remember those consensus statements I showed you, which talked about adding an additional drug if the LDL cholesterol remained greater than 70 despite being on a high-intensity statin. Well, if you remember to the start of this case, this patient was already on a high-intensity statin and their LDL cholesterol was way above 70. So we already know they're not going to achieve that target of getting less than 70. And again, I personally think based on the data that the target should be lower than 70, and we'll see what the most recent guidelines will say to that. But per the ACC consensus statements, it certainly would be reasonable to then consider adding an additional non-statin to that statin, either ezetimibe and or a PCSK9 inhibitor to really further drive that LDL cholesterol down. So that concludes the cases, and I hope you found this presentation educational.